This is an interesting case. This is tooth number 15, a maxillary second molar. The cusps are very worn. It's very difficult often to access a tooth that's worn. Some of the lengths aren't always applicable that are recorded in the textbook, so I use the CEJ as my anatomical landmark. I know that the pulp chamber usually begins at approximately the CEJ. So I'm going to get in there and quickly access this tooth. Again, using the CEJ as my anatomical landmark to where the pulp chamber should begin. As you can see, we've gone through a previous amalgam restoration. We want to keep that access as small as possible. I start usually in the central groove. The central groove to the pulp floor is usually about 5.9 millimeters. That's a really good measurement to remember. The distance from the pulp floor to the exit of the furcation is about 3 millimeters in a maxillary molar. So you've got 3 millimeters to work with there as you work in very calcified cases. Try not to go past the 8 millimeter mark. If you do, you're going to be pretty safe and you're not going to perforate the tooth in the furcation. That doesn't mean you need to keep your eye off the ball because you might go mesial or distal in that case. But again, going through the furcation on a calcified tooth, remember, use the CEJ as the beginning of your pulp chamber, and about 6 millimeters from the central fossa or central groove to the floor of the chamber is about 5.9 to 6 millimeters. In those cases, you're going to be pretty safe. Now, we've gone through, we've made our access, we've got access to every single one of the canal accesses, so we're going to refine that a little bit with the ultrasonic. I love using the ultrasonic. Now, this is not the same ultrasonic unit that the hygienist uses. The hygienist will use an ultrasonic tip that has metal stacks or strips that vibrate in a magnetic field. It creates a kind of an elliptical tip motion. It's not as precise. I use what's called a piezoelectric unit. It has a linear tip motion and it produces less heat and vibration and has a more precise movement. I still use lots of copious water when we do it because I don't like any sort of heat vibration. If you just put the tip on there, it will burn the tooth structure. But mostly the water is there to help clear out any sort of debris so that the visualization of that area is clear and we can locate the canal access and get into there as much as possible. So what I'm doing right now is I'm looking for the MB2. The MB2 is the canal that's the hardest to locate and is often the reason why most maxillary molars, first or second, fail. In most of the cases that I do retreat, it's an MB2 that has missed. You're going to notice, though, I use the ultrasonic tip a lot. I like the precise removement of tissue. It makes it so that the accesses can stay smaller, and I can get in there and remove the dentin without causing too much damage to the coronal structure. Now, in this case, we're going to be doing some troughing because I am looking for the MB2, the mesiobuccal second canal. The MB2 has a lower prevalence compared to those of the first maxillary molars, but it's still significant. In the CBCT, they've noticed that it's there about 40 to 70% of the time. Usually, clinically, it gets detected statistically 30 to 55% of the time. So I know that the vast majority of the time there's going to be an MB2. Thankfully, I always take a CBCT on every case so that I get an anatomical picture of where everything is. I know when I looked at this one, there was going to be an MB2. So I stuck around. I'm using my microscope, of course, with magnification to identify the MB2. As I use my ultrasonic, I'm going to trough that area. You can tell that I'm using a 10 hand file. It has a nice handle on it to locate it. There I'm locating the MB. It's pretty nice and easy. Here I'm trying to identify the MB2. I'm looking for anything that has a slight different appearance, kind of looks in the camera, it makes it look like a sparkle, but it's similar clinically. I'm looking for anything that has a different appearance to it. I'm going to get in there and find it, get a stick, and ideally that is going to lead to me being able to get in there and clean it out. Now, the MB2 is usually palatal to the MB1, often slightly mesial to the MB1 as well. It's usually about 2 millimeters lingual to the mesiobuccal canal, and it's often found along an imaginary line that you make in your head between the mesiobuccal 1 and the palatal canal. So when you're making the access considerations, it's on that line between the MB1 and the palatal canal in a straight line, or maybe sometimes slightly mesial to it. I use the ultrasonic to trough it along that groove, using my microscope always, and it helps me detect it. Now you'll notice in this, as I was talking, I located the MB2. I'm working down that canal as we speak, trying to enlarge it. We've placed sodium hypochlorite, and we're going to be using our rotary files. You'll notice that I don't use very large stainless steel files in my canals. They're very stiff. They're not flexible. Yes, I can put a pre-bend in them, but as you use them, they can transport a canal. This transportation can be in the form of a zip, which means you create this kind of a teardrop shape enlargement at the apex. It can cause ledging, which kind of creates this false step that prevents the file from negotiating the full canal length. It can straighten the walls, and you have this loss of natural curvature. In really severe cases, you can even perforate the apex of a tooth. So in the endodontic world, this is called canal transportation. We hate it. And so we try to use small stainless steel files, but we like to use our rotary files so that we maintain the curvature and the anatomy of the canal that we're working in. Now, you'll notice for the last few minutes that I've been working down all 4 of the canals. Started with the most complicated. I like to work with the MB and MB2, locate those, work down those, and then go to the palatal and then the distal buccal. The distal buccal in this case is a little more calcified. I've had to use my ultrasonics, work my way down. And again, I'm using my 10 hand file on a stick. This allows me to get visualization and also locate that canal. My fingers always seem to get in the way. In between, you'll notice I use a paper point. It helps also with the visualization. Sometimes the sodium hypochlorite or water distorts my angle and I can't really see what's going on. As you'll notice, I'm using the ultrasonic hand file. That way, as I migrate my way down the canal system, I only remove small amounts until I get a point where I locate that canal, and usually it's no larger than the diameter of a hair. It's usually very small, especially in these calcified cases. I'll go back and forth between the two until finally I get that stick. In some cases, I'll have to stop, take a new CBCT, make sure I'm not headed in a direction that I don't want to go. I do not want to perforate the canal wall. So as I go back and forth, sometimes it's frustrating for me, sometimes it's frustrating for the patient. It's definitely frustrating for the assistant. So as we do this, we're going to go down there just incrementally, always making sure that we are staying lined up with the anatomy of the tooth. While we sit around and watch me find that distal buccal canal, let's talk about it a little bit. In the maxillary molars, the distal buccal canal is usually found in that distal buccal corner of the pulp chamber floor. It's usually slightly palatal to the distal buccal cusp, and slightly mesial and toward the center of the chamber compared to where you might expect it. Often shorter than the mesial buccal canal, but it's usually fairly close to length of the palatal canal. It's most often really straight, or if it does, it has a slightly distal curvature. Uh, One of the things I've noticed is I'll get a lot of cases where it says they couldn't find the distal buccal canal to retreat case, and somebody's lived for years with an unobturated distal buccal canal because it is fairly difficult to find. It's there about 100% of the time in maxillary first molars, and it's usually there about 95% in the second molar. It can often be fused with the palatal or the mesiobuccal canal, creating kind of a C-shaped or confluent canal system. The distal buccal canal, as it merges with either the palatal or mesiobuccal canals at the apical third, it forms either what's called a type 2 or type 4 variation. Some of the common pitfalls that I find is that a lot of people fail to locate the distal buccal canal, especially in the second molar, because of the reduced chamber size and also calcification. Many times I will underestimate, many other people do too, the apical curvature. It's less common to have an apical curvature in the distal buccal canal compared to that of the mesiobuccal canal, but it can be hidden. It can have a slight distal or even a palatal curve that can complicate working length and obturation. Also, missed merging. The distal buccal canal may often fuse with the palatal canal, and it leads to under-instrumentation often. And this is those are the three common pitfalls that I find. The distal buccal canal in the maxillary molars is almost always present. It's usually singular, and is less complex than the mesiobuccal canal. Its main clinical challenge is its small size and the fact that it often merges with other canals. Make sure you're looking at the accurate location. Carefully explore the area with small files and verify with the CBCT or an angled radiograph. These are the keys to successfully treating the distal buccal canal. You know, one of the things I hear a lot is people say, I don't want to do root canals for a living, being an endodontist, because it can be kind of boring. And it is. This is what we end up doing most of the days, looking for canals. They can be tough. They can be challenging. However, it's the part of the whole aspect of doing root canals that I like. The hunt, the trying to find those difficult cases. They make you use your brain. They make you think. As you navigate this, oftentimes it gets tiring. The best part about doing a root canal is you have some either good music on, you have a movie on. In our office, we watch movies almost all day, every day, or documentaries. Patients really don't know what's going on. Oftentimes on the TV screen above the patient, I'll have the root canal going if they want to watch it. And most patients are absolutely fascinated as they watch you do a root canal. They'll often say, hey, is there any way you could do a monologue as you do the root canal? Because they liked watching it, but they don't know what they're looking for or what they're looking at. And so while I'm speeding it up here because it seems to take a long time, it does. Sometimes finding these canals can be a bear, but as you navigate slowly, it's so rewarding when you find it. Now, you'll notice here, I'm using some irrigant. It's EDTA. I have found the canal. Now I'm going to use my Rotary files to navigate those canals. I'd like to spend just a minute talking about Rotary files. But before I do, I want to remind you that we already talked a little bit about hand files and the dangers of using hand files in a large size. Nickel titanium Rotary files are much better today than they used to be. Traditionally, when I first started doing root canals, the nickel titanium files were about 55% nickel, 45 titanium, and it varied in between those. They were manufactured by machining. They had good flexibility compared to stainless steel, but they were prone to cyclic fatigue and they fracture, especially around a curved canal. Then we started seeing around 2007, 2008, a change. We had what's called the M wire, and they created that by a thermal mechanical processing where they would heat treat the file during manufacturing. And it results in a mixed kind of microstructure. And the key differences were it has some increased flexibility. It had definitely increased resistance to cyclic fatigue, and it was less likely to fracture around a curved canal. But things got better. Now, I use the Firewire by Edge Endo. Similar principles to the M wire, heat treated, but processed slightly differently. It has extreme flexibility. It can be pre-bent and hold a curve as I try and get into those canals, which allows me to keep my axis slightly smaller. It has high cyclic fatigue resistance. It maintains a sharpish cutting edge after multiple uses. However, I usually like to just use it one per case. You'll notice in a lot of cases, if you're watching, you can't see it because of the microscope, but I change out my files, especially my 15 and 20. They're kind of my workhorses. I change them out readily. They're kind of expensive, but as I navigate these really curved small canals, it's really helpful to keep a nice cutting edge on those files. So I'll have the assistant swap them out really quickly. Now, as you'll notice, right now I'm using the apex locator to identify the length of the canals. I'd like to stop talking about the rotary files. I'm sorry I talked so much about that, but I would like to talk about apex locators a little bit. I prefer the RootZX. It's the most accurate in most of the studies. I would also like to talk about file size. Many people say that the larger the file, the more accurate the reading. That's not actually correct. What you really want to do is get a file that fits snugly. The more the file is in connection with the wall of the canal, the more accurate your reading is going to be. So take a file that fits the canal that's been prepped, make sure it contacts the walls in a snug fashion, and your apex locator reading will be accurate. This is the most important aspect of getting a good reading. Don't touch metal. There are some studies that show that having a wet canal of sodium hypochlorite, EDTA, or any other substance does interfere slightly with the readings of the apex locator. So I prefer to go with a drier, not completely desiccated, but a drier environment. And you want to make sure that the file fits the canal that you're working in. If it does, you will have a more accurate reading. In this case, I decided to go with a very standard cleaning method. I'm going to start with just my normal rotary files. You're going to notice that I'm using the white file in this case, which is a 1504 taper. The file size number corresponds to the diameter of the tip, measured in hundredths of a millimeter. For example, an ISO number 10 file equals a 0.10 millimeter at the tip. An ISO number 25 file measures at 0.25 millimeters at the tip. When I'm cleaning and shaping, I begin first with kind of a modified crown down. A real crown down cleaning method starts with a really large file, like around 4004, and you step your way down. I like to do kind of a modified. I start kind of in the middle. I start with a 2004, clean and shape, then I go to a 1504. Now, I find that my 1504 in the Edge Endo file is almost indestructible. I can peck my way down almost any canal with that. And in that case, once I get to my 1504, I work my way back up to the file size that seems to have the most resistance. My workhorse has turned out to be this XD3 shaping file by Brasler. It's kind of an amazing file. The amount of debris that you're able to pull up with that file
is amazing. I'll get down to working length with that. It equates to probably around a 3004, but its cleaning modality is pretty amazing because it's able to hit all of the walls of a canal. And again, if you'll clean with a 3004 and then go back in with that 3D shaping, you're going to bring up so much more debris because it's able to hit so many different walls. Now, I'm always irrigating. I've got it on a faster speed here for the irrigation. The sodium hypochlorite is the most important aspect of anything that you're doing. The mechanical cleaning that you do with the files is wonderful, but the chemical cleaning that you get with the sodium hypochlorite is actually what does all of the work. Now, again, we're only doing a very classic endodontic treatment in this one. We're going to clean probably up to a 4004 in the palatal, a 3004 in the distal buccal, a 3004 in the mesiobuccal and the MB2. We're going to always use copious amounts of sodium hypochlorite, but it's passive irrigation, meaning I'm using a tip. I'm irrigating down to about 2 millimeters short of apex when I'm finally doing it or finally completing the case. Actually, in this case, it looks like it went up to a 4504. You'll notice that's a white one. We start with the white again. 15 is white, 1504, and then the 45 is also white. So in the palatal canal, we cleaned up to a 4504. Lots of effervescence. Now, the yellow tip in this case is EDTA. EDTA. When we talk about EDTA and endodontics, the first thing to know is that it's one of the most important irrigation solutions. EDTA stands for, and I'm going to kill this name, ethylene diminotetracetic acid. And in our field, it's usually at 17%. Its main job is to remove the smear layer. That forms whenever we instrument a canal. Now, what is a smear layer? When we cut dentin with files, we create a mixture of ground up dentin, pulp, tissue, and sometimes some bacteria. This layer coats the canal walls and plugs the dentinal tubules. If we leave it there, it blocks our irrigants, sealers, and medications from penetrating effectively. That's why we need to get rid of it. Here's where EDTA comes in. EDTA is what we call a chelating agent. The word chelation comes from the Greek word claw. Think of EDTA as a chemical claw that grabs into the calcium ion. Dentin is full of calcium in the form of hydroxyapatite. And when EDTA binds to that calcium, it dissolves the inorganic part of the smear layer. That action does two important things. It removes the mineral component of the smear layer, while the sodium hypochlorite handles the organic compound. It opens up the dentinal tubules, which improves penetration of our irrigation disinfectants and later our sealer. Now, in simple terms, sodium hypochlorite breaks down the soft tissue and the organic debris, and EDTA removes the mineralized debris. Together, they give us a clean canal surface that's ready to be disinfected and sealed. Now, you notice here I'm placing the sealer. This is a bioceramic sealer by Brasseler. We're placing the cones. We've already fit them. We've got a 4504 cone fitted to length with a slight tug back. We're going to burn that down just pretty much at the orifice. We're going to pack it down nice and tight. I'm going to now fill the distal buccal. I go in the same order every single time. If you make it consistent, it makes your life easy. You think less. Then I go to the mesiobuccal. Now my mesiobuccal and my mesiobuccal 2, they join. A type 2 kind of feeling there. So we're going to put that in there, seal it off, pack each one of these down, make it nice and clean. I do a little bit of a backfill just because I want to fill it up just a little higher. I think it looks better on the x-ray. Does it make the case better? Probably not. I don't have any literature that supports backfilling it just a bit, but I still do. Pretty much this is a cone, single cone obturation. We're going to place that nice and tight, pack it in there. Now, I'd love to talk more about the sealer, but I'm not going to in this case. We're going to clean everything off with our ultrasonic unit. Remember, I love the piezo ultrasonic unit. It does everything very clean, gets every debris, all the debris out of there. It's beautiful. We have a nice clean case, all 4 canals cleaned and shaped. I'm gonna kind of tidy it up here just a bit. I like the edges down. I don't want anything up. I don't like it when it looks crappy on an x-ray. I'm going to place a glass ionomer over the orifice, kind of a varnish that we place over it to seal it, to protect it. The patient, in this case, is going to go back to the doctor for the core and the crown. The doctors dictate usually what we do. I place a sterile foam in the orifice, then I place the cavit. The cavit is an amazing substance. Again, we can talk more about cavit in another one of our cases, but cavit works great, small accesses. Sometimes it doesn't hold up as well, but in many cases that can be good because it urges the patient to quickly return to their general dentist for a core and crown. As we clean that up, we're going to remove the dental dam, and we're done. Hope that helped everybody.